Hi, welcome to Back to the Suture. I'm the author of the bestseller Back to the Suture textbook and also the creator of the Back to the Suture training suture pad that you have in your hand right now. This suture pad has been designed to so that you can practice the principle of the knots using the shoestrings and also in the partially edentulous maxilla area, healing abutment, extraction sockets, and mandible, edentulous mandible, and everything. So if you master suturing in these situations, when you go back to your clinic, you will have no problem to do the beautiful suture techniques. Now, let's begin with the principles of the knots before we actually jump into the suture techniques. What I have designed is you have a red shoestrings here and you will have a blue shoestrings. So if you put the shoestrings from bottom to up, this is the incision line and these are the sutures. So in dental clinics, we do not do a lot of hand-to-hand suture, but we use the instrument tie. But at least you can see what's going on when you make knots because these shoestrings are bigger than the actual sutures. So the first knot that we want to practice is the square knot, the ideal and the ultimate knot of all the knots. The square knot usually starts from the right over left. If you start with the left over right, doesn't make any big difference, but easy to remember, right over left. As you can see, red goes above the red, the blue, rotate. That is the first throw. And for the second throw, left over right. I started as a right over left, and then this time it's a left over right. If you make a tie, this is the beautiful square knot. If you make a line, if you draw a line here, you will see that they are all identical. It's actually symmetry up and down. And it looks like these U-shaped rings, these U-shaped loops are actually pulling together. That's why square knot is very good at securing of the knots. So this is the square knot. If you want, you can start with a left over right. So left over right and right over left. And again, you will have exactly the same symmetry of the square knot. So if you start with the left or if you start with the right, doesn't make a big difference unless you have to keep the one string going over and that string needs to go over again. Let me clarify. Red string goes above the blue. Okay, red is above. Rotate. And again, red goes above again. The same string goes over and over again, then you get a square knot. If you start with a left string, like a blue, goes over, and the blue goes over again, and if you make a tie, this is again the square knot. So please keep in mind that the square knot, the string which went over should keep going over again. But if your grandmother has listened to this video and she went home and to practice for the knots creation and she got misunderstood and a little bit confused and she says, okay, the red one goes above and then right one goes above. And this is a confusion, right? And if you make a tie like that, this one has no symmetry at all. And if you tighten it up, there's a rotation of the knot. This is a granny knot. This is the knot that we don't really like. If you make a granny knot in your clinic, then there's a very high chance that you will lose the knot. If your patient comes back to your clinic with the missing knots, that means that you probably have created a granny knot instead of the surgeon's knot. So what grandmother has misunderstood is red, right, doesn't matter. If one string goes over, the same string has to goes over again. So red over the blue, and again red over the blue. And that is the square knot, not granny knot. So if you made a square knot just like this, what we see in a clinical situation is this loop, we call the loop security. Loop is very loose. You create a tie and the knot is really tight. Knot security is good, but the loop security is too loose and you will have an opening of the wounds. You don't want that, right? So in order to have a secure loop security, what we do is we increase the friction. So instead of going one throw, we go twice. So red goes above the blue once and twice. Now we have a better friction. And if you pull the string like this, from that friction, the loop security is maintained. And then above, we make a small throw like that. And then if you tighten up, this is the variation of the square knot, and it's called surgeon's knot, the basic knot for all the surgeons, which will increase the loop security and also it will make the knot very tight. So 2 by 1. If you want additional security, in this case, it doesn't matter. The red goes above, blue goes above, it doesn't matter. Just create an extra knot. And then this is a 2 by 1 by 1 surgeon's knot. So with this information, why don't you stop this video at this time and then practice these knots, and then please come back. Good, welcome back. Now we are studying with the suture number 1, interrupted suture. Before we actually do the suture, I want to talk about the instrument. The needle holder is on your right hand, tissue plier is in your left hand. So this is the basic stance that you do the sutures. Sometimes I grip my thin scissor or small iris scissor in my palm, and then above I hold a needle holder. So it actually helps me to change the instrument rapidly. But if you are not really focused with the speed, you can drop down the needle here and then only focus on the needle holder. As you can see, I'm holding the needle holder in a very weird way, right? You were taught in the textbook to grip the needle holder just like this. This is a tripod grip or foregrip or thumb and third finger grip. You stretch out the index finger and you put the rings in the thumb and the ring finger so that you can make a rotation just like this. This is good, but there's a limitation of the rotation of the wrist. So instead of the tripod grip, I really prefer the reverse grip. You put your thumb and index finger into the rings, and then you stretch out the middle and the ring finger to support. And with this, you can make a various modification and the variation, and the needle holder can rotate going up and down, away from you and near to you, everywhere. So I really like this reverse grip, which is my favorite grip. While you're watching this video, why don't you practice this reverse grip, and really in your clinic, it might help you. Now we start with the interrupted suture first. Now look at this edentulous mandible here first, and we will start the interrupted suture. The tissue plier holds the flaps, and you engage the flap, go in and come out. This is not straight movement, it's a rotation. Because the needle has a curvature, your needle should curve, rotate like that. And again, grab the lingual flap and rotate. Now, you grab the tip of the needle, do not push straight, make a rotation, curvature. Follow the curvature of the needle and pull the strings all the way until you have a 3 or 5 centimeter short end. So this is a short end. Now, you drop your needle, to the surgical field, and with your left hand, you grab the suture very near to the surgical site, which should be very near to the mouth. If you grab the suture very far away, then the suture is too long. You will have a very complicated situations. So what I recommend is drop down the needle, grab the suture very near to the mouth, and it's a very concise and confined situation. So it will be better to actually make a very good suture. Now, there are steps that you have to follow. Step 1, place the needle holder above the incision line. Step 2, rotate your suture around the needle holder. Step 3, grab the short end and make it cross the river. So short end was here, but now I'm passing the short end to the other side. So my right hand goes this direction, and naturally my left hand goes to the opposite direction. So this is a first throw. As you can see, it's beautifully created. And then you let it go and you follow the second step one more time. Before you do that, you can see that my loop security is very loose already because there was a minimal friction. What we can do is snap. You can give a snap to the first throw so that the knot is kind of buried in the soft tissue, and then if you just let it go, it kind of maintains its friction. So it's really easy way to maintain the loop security. Now, step 1, needle holder goes above the incision line. Step 2, the suture around the needle holder. Step 3, short end crosses back to original position, so it will be this way, and your left hand goes to the other direction naturally. And this is the square knot, and this is the interrupted suture. Beautifully done. Now let me do the interrupted suture one more time. Grab the tissue with the tissue plier, apply the needle, and make a curvature rotation, and again another rotation. Grab the needle, do not pull straight, but make a curvature, and then let the needle escape the soft tissue. Pull the suture all the way until you have a 3 centimeter short, really short end. Drop the needle tissue plier, drop the suture to your left palm, and then step 1, needle holder above the incision line. Step 2, rotate around the needle holder. Step 3, short end crosses the river. Step 1, first step, throw is over, and do a little bit of snaps so that your soft tissue kind of holds the tension of your first throw. Again, needle holder above the incision line, and then suture around the needle holder. Grab the short end, crosses back, and your left hand goes to this direction, and then if you tighten up, is the square knot for the interrupted suture. Now, if you do a surgeon's knot, you make your first throw twice. So let me show you how it's done. Buckle, lingual, pull out, short end is 3 centimeters short, drop the needle, drop the tissue plier, drop the suture, 1, 2, rotation, short end crosses the river. This is the first throw. And as you can see, I didn't do any snap, but the friction is maintained. So this is the reason that we do a lot of a surgeon's knot, but still the silicone has a lot of resistance. So I think that you can practice do a little bit of snap. And then again, the short end crosses back. And this is the interrupted suture with a surgeon's knot. So at this moment, stop this video, practice interrupted suture with the square knot and the surgeon's knot, and then come back, please. Now it's time to do the figure 8 suture. Figure 8 suture is usually done around the implant healing abutments. What we usually notice is the soft tissues around the healing abutments, they climb up over the healing abutments, and later you have to get rid of the excessive soft tissues around the healing abutments. And you don't want that, right? So just by changing the suture techniques, you can actually press down the soft tissue so that they do not climb over the healing abutments. And this suture is called figure 8 suture. For your information, the figure 8 suture that the medical doctors call and the dentists call are totally different. The figure 8 suture that we call in the dentistry field is performed like this. You engage the buccal flap first. Again, always the same, the rotation. Never push directly. Grab the needle and make a curvature and pull out. Pull out until you have a very short end, 3 centimeter or 5 centimeter. And then you're supposed to go from the buccal to lingual, but in this case, you reverse your needle and then you come back from lingual to buccal on the lingual flap. And then if you pull the sutures, you will see between these two flaps, the sutures are running between these flaps. And if you make a tie, if you want to make a surgeon's knot, if you want to make a square knot, doesn't matter. The knot doesn't matter. But what you see is if you pull the sutures, the flaps are pressed down. The flaps are pressed down from buccal and lingual. And they kind of press down and maintain the tension so that the soft tissue cannot never climb up over the healing abutments. So this healing abutment, the figure 8 suture, is really ideal to press down the soft tissue around the healing abutments or around the resin restoration with the very deep subgingival margins or something like that. So this is the figure 8 suture. But one catch with this figure 8 suture is when you remove the figure 8 suture, if you cut it and if you pull it, this portion exposed to the oral cavity is kind of, as you can see, pushed in to the flap and then it comes out, which means that all the plaques and food debris has been exposed over the week is now inserted inside the flaps. So there's a chance of the slight infection or inflammation. So that's what we have to be very, very, very careful. But actually that does not make a big difference. So don't worry, but still you have to understand figure 8 suture has a disadvantage of this kind. Now, At this point, stop this video, practice your figure 8 suture around these implants, healing abutments, and then come back, please. Now it's time to do some eversion actions. This is called horizontal internal matrix suture. So we start with a conventional interrupted suture, buckle and the lingual flap, rotational movement, pull out, also the rotational movement. And then if you make a tie, this will be an interrupted suture. But stop and reverse the needle and comes back from the lingual to buckle at the same level. And then if you pull out the needle, what you will have, two sutures are running inside the flap. Do you see that? This is why it's called horizontal internal matrix suture. So if you pull the sutures and create a knot, I hope you can see that. If you really apply a lot of tension here, and then you will see that these 2 points are kind of pinched like this. And then it's like a paper clip. If you apply the tension from this horizontal internal matrix suture, these flaps are pressed and these soft tissues along the incision line is pushed up so that you can see that these flaps are everted, which will really accelerate the healing because the inner portion of the flaps are met together. So for the GBL or some area which should be really healed rapidly and fast, you can do the horizontal internal matrix sutures, and this will help you to achieve the security of the flaps after GBL, and then also you can actually prevent wound adhesions or exposure. After this horizontal internal matrix suture, as a clinician, you are tempted to do additional suture along the incision line, as you can see, because these lines are open. So we create additional interrupted suture. That's the human instinct. As a clinician, I know you want to close up on the upper portion because you don't want to jeopardize the whole surgery, not doing a single suture. And then if you make a tie and the incision line is secure and you're happy and you can make a good slip, right? But the thing is, this is two separate sutures and it takes time and you have to remove the sutures twice, and actually the clinicians wondered, can we combine these two sutures into one? And that's exactly what the Professor Laurel did. And then he came up with this very brilliant suture technique called modified Laurel suture. Let me show you. This modified Laurel suture actually combines these horizontal internal matrix suture and the simple interrupted suture at the same time. And the suture technique is not really difficult. So after you practice this one, I'm pretty sure that this suture technique will be your favorite suture technique because it is my favorite suture technique too. Now, it is exactly the same, just like the horizontal internal matrix suture. Coming from buccal, come out of the lingual, reverse the needle, and then come back from the lingual to buccal. And if you pull out the suture and make a tie, then it's totally horizontal internal matrix suture. But if you pull the needle, and then you will see that the loop is secure, the loop is created. Do you see that? This loop, the needle is passed through the needle. The direction doesn't matter. You can enter from here, you can enter from there, doesn't make a big difference. You enter and pass the needle through the loop, and then if you make a tie, underneath there is a horizontal internal matrix suture. As you can see that the flap is everted, but also at the same time, the loop actually protects the incision line just as an interrupted suture does. And this is combination and the mixture of the horizontal internal matrix suture and the interrupted suture. And it's called modified Laurel suture. Now, at this moment, watch this, stop this video and then practice and then come back, please. Now it's time to do the horizontal external matrix suture. Horizontal external matrix suture does exactly the opposite of the horizontal internal matrix suture. Horizontal internal matrix suture everts the flaps. They push up the flaps, but the external matrix suture presses down, inverts the flaps. So how do you do that? So just grab the needle, and then if you pass the needle through the same flap, I have been going from the buccal to lingual initially, but you do not go buccal to lingual, but just like the ice cream scooping, you pass your needle from the buccal to buccal. In this case, distal to medial. And then grab the needle, and from the opposite direction, you pass your needle and scoop up. A little bit, I'm going to change the direction, and then it came out. Now, it was a distal to medial, and then this time, medial to distal. So the opposite direction, and then if you pull out the suture, the shape of the suture will be just like a 11, number 11. Two silk are running outside the incision line. That is why it's called external matrix suture. The sutures are outside. And if you really tighten up, as you can see, the sutures are pressed down. You will see that the lumps are created because the sutures are buried, pressed down. And then what they do is press down the flaps, inverts the flaps at the same time. So this is the horizontal external matrix suture. So it's quite a powerful suture, but honestly, I never use it. So for the educational purposes, I demonstrate of using it, but in fact, in a real situation, what is the purpose of two lines pressing down the flaps? There is no meaning. Rather, if you can actually press down a single point with a suture in the clinical situation, then it will be meaningful. For instance, you want to press down the soft tissue near the tooth, or you want to press down at the distal aspect of the molars, then it is useful. But other than that, the 11 number marking, pressing down, it's quite useless. So what I recommend you to practice is, instead of the horizontal external matrix suture, why don't you practice the crisscross suture? And it is done just like this. The horizontal external matrix suture was the opposite direction, but the crisscross suture is the same direction. For instance, medial, and that's too far. Let me do it again. Okay, medial to distal, and then pull the strings, 3 centimeter, stop. And again, same direction, medial to, let me catch more, medial to distal. Okay, And then you pull out the needle, and what you will see is the X mark is created over the flaps. And if you really tighten up, the sutures are pressed down just like the horizontal external matrix suture, but in this case, the crossed portion, the X mark, and the center of the X mark is the most pressed down area. So it's a single point to press down the flaps. So instead of the horizontal external matrix suture, I do a lot of crisscross suture. I hope that it's be very useful in your clinic. At this moment, stop this video and perform the horizontal external matrix suture and the crisscross suture and come back, please. Now, when you have an extraction socket like this, let's say you did a bone graft after extraction, what would you do? Definitely you will do this suture. Enter from buccal, grab, and come out from the lingual, and then come out. And then you come from the buccal, and then you come out from the lingual. So what is this? This is a kind of a continuous suture. One interrupted suture, two interrupted suture. And then if you make a tie, it becomes like this. X mark is created on top of the extraction socket, and it's called X suture. But the thing with this X suture is if you really tighten it up, what happens is you crush the extraction socket. Do you see that? The opening of the extraction socket was quite big, but after your X suture, the whole orifice is squished. And actually, what is the meaning of the ridge preservation when you do the suture just like that? You already fail to preserve the dimension. So instead of doing this X suture, I have created the hidden X suture, which is the best suture when you do the extraction socket management. Let's say you come from the buccal aspect. For the X suture, you go straight away to the lingual side, but for this aspect, you came out from the lingual in an oblique way. So please don't be confused. Buccal lingual, but done in an oblique way. That's how you achieve the hidden X suture instead of the X suture. And the beauty of this hidden X suture is X has been used to be outside from the X suture, right? But now it's inside, so it's called hidden X suture. And if you make a tight tie, you will see. Do you see that? Instead of the buccolingual crushing, I do my best, but buccolingually, they are not affected at all. Maybe they are pushed mediodistally, but still they maintain their orifice. So this is the hidden X suture, ideal for the ridge preservation and also the protection of the bone materials and the membrane inside the extraction socket, although it's an open healing situation. So this is how I do a lot of IGBL, I call it the immediate GBL case after the extraction, and it gives me always a good bone regeneration and the wide keratinized tissue regeneration. At this point, please stop this video and practice X suture and hidden X suture and come back. Now this is our final video. There are a lot of good, useful, fantastic sutures, but due to the limitation of the time, this is the end of the instructions. If you are a little bit want to learn more, please visit backtothesuture.org. There will be tons of information, cases, videos, and everything will be available. Now, the final suture that I want to recommend is the flap folding suture. This is done near the implant, the healing abutment, and the buccal flap. At some time, the lingualized incision creates very excessive amount of the buccal flap creation. What we want to do is press down and secure them so that they do not climb up over the healing abutment. Sometimes you have to cut it out, but it's so precious keratinized tissue, so you don't want to cut it out. You want to save it. And how we can stabilize it. This is the flap folding suture. You come from the lingual side, come out, and you scoop down the buccal flap, which means that you come in and come out, and which should be done only in the keratinized tissue. So you do not come out of the mucosa, you enter, you come out from the same keratinized tissue. Reverse the needle from the bottom to up, come back, sorry, again, there you go, oops, one more try, yep, there you go. Another scooping up, and then you go to the lingual side, just like that. Now what you will see is two 11 mark parallel sutures are pressed down, and the flap is pressed down. It's not roll technique. They are not rolled, but they are kind of folded and pressed down. So that's why it's called flap folding suture, not rolling suture. If you make a tie, and you will see what I mean. The buccal flap is really, really tightly pressed down. And then do you see that the difference between the actual level of the flap? The buccal flap is pressed down and it's lower than the lingual flap, right? So this is the flap folding suture, and this will maximize the utilization of the keratinized tissue around the implant, especially on the buccal aspect. So this is the flap folding suture, and this is a really, really useful suture which can be done around the implant's healing abutments. Now with this, I'd like to close my session on the Back to the Suture lecture, and if you have any questions, please visit my YouTube channel, The Future Ready Lab, or Facebook, Yonsei Magic, or from the Instagram, Dr. J.C. Park, Professor X, or just visit the website backtothesuture.org. Thank you, everyone.